All right, well, welcome everyone to Sparked HL7 AU eRequesting TDG group meeting for Thursday, the 24th of April. This is a pretty small meeting. There's about 10 of us here. We have determined that we do have a quorum, so I think we are going to proceed since people did vote to have this meeting. All right, excellent. If anyone has any objections to that, maybe now would be a good time to mention it, and we'll see what we can do. Right, so let's start off with a quick acknowledgement of country. We acknowledge the traditional custodians of the lands on which we are gathering.
Yeah, I can have a look. It's legit.
And we pay our respect to elders past and present, and extend our respect to
Office.
Aboriginal
Yeah,
and
it might be Microsoft Office. So Excel, how.
All right, so the agenda for today, bit of quick business, approval of minutes, and I don't think there's any other updates really, except for a quick note about an upcoming event, and then Angus is going to spend some time talking to us about clinical context features and diagnostic request supporting info. So we have meeting minutes from the last meeting. Let me just bring those up. These are the eRequesting TDG minutes from the 10th of April, scribed by Stephanie. Would anybody like to motion to approve those minutes? Anyone? Bueller?
Yeah, I'll motion.
Thank you, Andy. And a second, please.
I would say second, Zoran.
All right. Quick poll. Let's get that out of the way. You just need to vote on whether you are confirming, abstaining, or voting in the negative. And that one is approved with 6 votes in the affirmative. Thank you. All right, so a few action items on the list. I've been advised that they're all still in progress, so we won't go into those in too much detail. The next note is that there is a Sparked testing event on the 24th of June in Brisbane. So there is a QR code on your screen right now. Do we have a link for that? If anyone can grab the link and put it in the chat, that'd be great.
The one hidden in the barcode, you mean?
One hidden in the barcode, yeah. So that's an in-person event, and we're going to be testing AU eRequesting along with AU Core and AU Patient Summary. All right, so I think Angus is actually just putting the link in the chat, but we are going to hand over to him in a second, and he's going to talk to us about some clinical context stuff.
I don't know if I'm the best person to put the link in the chat.
All right, do you want to start sharing?
Yeah, I'll start sharing.
All right.
Share button. Right. You see my screen? Yeah, hang on. I'm starting with my PowerPoint presenting on the wrong screen. Put you over here. And slide. No, it doesn't work either. Let me stop sharing and I'll share the other screen. Oh yeah, is that better? We see the big orange clinical content feature discussion.
Yeah, we've got that now.
Yeah. Okay. So, how do I progress? From beginning. All right, I'm struggling with PowerPoint. Move to next slide, please. No. From current slide, from beginning. Yeah, there we go. There we go. Okay, so so this discussion is about what they've been called the clinical context feature. Here is the definition that we're given by eRequesting, so the clinical group. I guess in summary, it's what we would traditionally call clinical notes on a request form. So a narrative, information providing an overview of the individual's current clinical situation. It's deemed to be optional, single occurrence. It's just a string, and an alias for it is clinical notes, as I said. This data element describes the broader clinical background or circumstances related to the request, supporting the service provider in making informed decisions about service delivery. Historically, many paper forms feature a section labeled clinical notes to document relevant background content for each service request. This data element has been purposefully named clinical context to semantically differentiate it from the more generic comment, which allows clinicians to record any additional information not captured in semantically specific data elements. So if I summarize all that, we're talking about what is traditionally on a paper form called clinical notes. It's usually just a box with a heading called clinical notes, and the doctor tends to write whatever he likes in there, but it's meant to be clinical in nature. It today can be anything from a specific comment about one of the tests. It could be a global comment like the patient is HIV positive, and doctors write all sorts of other crimes in there as well. So that's our remit from the CI team, is we need to support that concept. We discussed this at the last meeting as well. So we already made a decision about we need the service requests to point to a common resource that's going to hold this content, this string data called clinical notes. And where we're at the moment is trying to decide what that resource would be that the service request points to. And just maybe, so we have the context. This is the service request. This is just R4's service request. We're really talking about this here. What would it point to? Because it could be anything in order to provide clinical notes. And I just highlight too, we have this field called note, which is also effectively just a string. It's an annotation, which they define as any other notes and comments made about the service request, for example, internal billing. So we've already made the decision that we want this to point to a resource. This suffered the problem that, let's say you did want to say patient is HIV positive, you'd have to say that on every resource, not just one of them, because each resource is a test or an exam. And then that becomes complicated for implementers, because if you write HIV positive here and you've got 10 tests and you've written it 10 times, it's very difficult for the receiving system to possibly deduplicate that and say, hang on, we just need to say patient HIV positive, not 10 times, but once. By using supporting information pointing to a common resource, that makes that task much easier, because you only say it once in that resource and all the resources point to it. We've already made that decision. I'll come to that a bit later, but now we're just trying to decide what is the resource that's going to hold this clinical note or clinical context. So we've done some digging, and we have come up with these 3 candidates. Welcome for anyone else to think of a 4th if they can. So document reference, each of these are FHIR resources, observation, and clinical impression. So we did have this discussion page here. Sorry, go back. Oh, go back. Backwards. The other click. Previous. previous. We did have a discussion page running, which was here. So here we talked about it. Most of this content is in the slide deck. There's comments down the bottom, which I'll come to a bit later. They're more related to the second point. So let's explore these three, I suppose. So document reference represents a reference to a clinical document. So it's the idea of you have a resource that points to what could be another document, but for our use case, we would just have the string in that document reference. So it would really point to the data within the document reference, that being a string. Observation is typically used heavily in pathology for like recording numbers and hemoglobins and platelets counts and all sorts of things. You could have an observation, a simple observation that is of type string. So measurements and simple assertions made about the patient, device, or other subject is another option. We'd need to find a code as what to call it. And then the third option was clinical impression, a record of a clinical assessment performed to determine what problem may affect the patient. I might go backwards through these. So clinical impression is not that well aligned, in my view at least. If we go to just the spec, get there. So here's clinical impression. So a record of a clinical assessment performed to determine what problems may affect the patient and before planning the treatments or management strategies that are best to manage a patient condition. Assessments are one-to-one with a clinical consultation or encounter. But this varies greatly depending on clinical workflow. The resource is called a clinical impression rather than clinical assessment to avoid confusion with the recording of assessment tools such as APGAR score. So I don't know if this really fits our use case. We're talking about a little bit of information given with the request. You might make many requests in one consultation, so it's kind of not one-to-one. It's more about doing a clinical assessment. Well, our use case isn't really that. You possibly are doing a clinical assessment, and the result of that is you're ordering pathology or radiology, but the clinical notes within those orders aren't really the outcome of the assessment. They're just a component of the assessment, I suppose. I'm not sure if clinical impression is a good match, even though by name it sounds reasonable. Observation. Observation is essential element to healthcare, used to support diagnosis, monitoring progress, determine baselines and patterns, and even capture demographic characteristics. Most observations are simple name value pair assertion with some metadata, but some observation group other observations together logically or even in multi-component observations. Note, Diagnostic Report resource provides a clinical or workflow context for a set of observations, and the observation resource is referenced by a Diagnostic Report to represent laboratory imaging and other clinical diagnostic data for forms and complete report. So uses of observation resource and vital signs, laboratory data, imaging results, clinical findings, device management, clinical assessment tools such as APGAR, personal characteristics, social history like tobacco, smoking, family, and core characteristics like pregnancy status and death assertions. But again, our use case of like clinical notes is very varied, right? It's not just the pregnancy status. It's not just HIV status. It's all manner of things. Where observations tend to be quite discrete, like value pair. This is your pregnancy status. This is your hemoglobin result. This is your tobacco use, not general in nature, like here's some general commentary about their clinical context. Get back to the slides again. And then document reference. So document reference. Yeah. A reference to a document of any kind for any purpose provides metadata about the document so the document can be discovered and managed. The scope of the document is any serialized object with the MIME type. It could be like PDF or image or JPEG or text or all sorts of things. So it includes formal patient-centric documents such as CDA, clinical notes, scanned paper, and non-patient specific documents like policy text. So it literally does say clinical notes here, which is one highlight, I suppose. It's really just a pointer to any document. But we are able to put the content directly in it. Now, next slide comes to that a bit. So there's three options. Let's go to the next slide. Here's a comparison someone's done, trying to sort of do positive and negatives of those three options. So, fit for unstructured clinical narratives. So document reference, good choice for encapsulating clinical narratives such as clinical context, referral notes. Observation, the broad nature of clinical notes doesn't seem to fit the intended scope and usage of the observation resource. And clinical impression, designed for assessments rather than narratives. Resource supports categorization of clinical notes. Inherently, so document reference inherently supports document type code, binding with referral note being the potential candidate for clinical notes. So they're suggesting that we would put a code on our document reference of referral note. Separation from other supporting information like pregnancy status, modeled as an observation, which is important for deduplication of common supporting information. Observation, no suitable codings for observation category or observation code to distinguish an instance as a clinical note as has been identified. I struggle with that, given we just were quite happy to say this code was quite good over here, but that's just my view. Ease of implementation for plain text. Overhead in managing plain text clinical notes as base 64 encoded content or links. Because what they're trying to say is if we use document reference, the string content has to be base 64 encoded into that resource. That has the slight implementers overhead, for the tech people working in the background, is when they look at the document reference, they can't just visually see the clinical note. They're going to have to unbase 64 encode it. So anyone who looked at the resource would just see gibberish. You'd have to run it through a processor to get the text out of it. Simpler to implement for plain text using value string, but this may be considered semantically inappropriate for the broad nature of clinical notes. So yes, you would be able to look at the resource and just see the clinical notes written as plain text, but they're making the point that observations are typically quite granular, like this is your white cell count, your pregnancy status is this, not broad in nature, which our clinical notes really is. Support for multiple formats. Supports various attachment formats. However, it may need to be constrained for AU requesting as the MIME types, as any MIME type can be exchanged. The document reference as it is can support all sorts of things. The document doesn't have to be plain text. It could be a PDF, it could be an Excel spreadsheet, it could be a Word document, it could be a JPEG. There's just a litany of references it could be, but initially we would look to limit it to just text. But the point being that in the future, if we looked to expand to this, the capabilities there, I don't know, I can't predict the future, but if in the future we decide that clinical notes should be passed around in PDFs, then it would be easy to make that change here. You just change the MIME type to PDF and you could do that. But initially, to reduce our complexity, we would just restrict it to plain text at this point in time. Observations support for attachments using value attachment, but this may be considered semantically inappropriate for broad nature. So you can attach an attachment to an observation, but you would still need a value pair, right? So you'd still have to say, this is a clinical note, nothing, and then in the attachment have the clinical note. So whereas on the left, it's nothing but a reference to content, where here it's like a value and an attachment. And again, it's broad nature. It's not distinct. Clinical notes is very broad. Clinical impression, no native support for attachments or content encoding. So you can't attach anything to a clinical impression. Alignment of other IGs aligns with existing approaches for exchange of clinical notes, the US core. So in US core, I don't know if this link's going to work for me. It's not. In US core, they do use document reference for clinical notes, which is a big flag, I guess, for us. Observation not aligned with intended scope and usage for observations, someone's view. US core notes, it did not find the boundary between clinical notes and clinical impressions clear enough to leverage the resource to share clinical notes. So that was US core's reasoning for using document reference against clinical impression. I don't think they even entertained the idea of observation. Extendability for eRequesting can be profiled to constrain and can be profiled to constrain and support document formats as needed, i.e. support for plain text now, and then support for other MIME types, applications /PDF in the future, possibly. Limited extensibility for documents like use, designed for assessments rather than narratives. So that was someone sort of, you can see we're leaning toward document reference. Just look at the next slide and I'll go back. So has anyone, I guess I'll open up. Has anyone got any questions or comments at this point?
Oh, I guess I'm always good for a little comment. How are you going today?
Hey, David, how you going?
Yeah, good. I guess it's the data and the definition of data that I always sort of fall back on just to make sure that get the grounding right. And that word observation. And again, the way I guess we've been looking at it at the PHNs is to recognize that it is an event. There's an observation. Oh, geez, look, something happened. We created data with this event. And what we've done is said, oh, so what did you see? Oh, we saw a measurement, or we saw this, or we saw that. So we sort of separated the capturing of, let's say, your blood pressure from the fact that, oh yeah, in this encounter with your doctor, he made an observation and collected 2 pieces of measurement about you. So we were trying to get right down at that atomic level. That's not what we're doing here, though, is it?
Yeah, I think that's the criticism of using observation for what we're looking for, is that we're trying to capture something that's very broad. Clinical notes. It could be anything. It could be, the patient's feeling anxious, the patient's got a fever, and many things, right? It's not one thing. I don't think we're proposing that doctors have to create an observation for each statement they say. It's more a written, maybe a couple of paragraphs, maybe a couple of lines, just there, what they want to tell the filling system, the pathology provider or the diagnostic imaging. It's sort of, oh, and I need to tell you this.
Yeah.
As opposed to, like, as you were saying, like, I've taken their blood pressure and I've recorded the number. That's an observation, right? Like, and
then I've got a document. And by the way, with that number, I'm thinking this is a problem. And here, have a look at this document. Is that a clinic, like the clinical or whatever the?
It is very broad. I struggle, even though it's called clinical notes and that's its intent, it becomes the scratch pad that the doctor writes in to communicate whatever he wants to the provider, right? Wrongly or rightly,
Yeah. Cool. Zoran, good to hear you.
Yeah. So I think for me, the distinction is between service intent, what is expected to happen. And I think service request really is about that intent. And that's why observation and clinical impressions to me don't work, because they are really about capturing of something which has happened, and they don't capture what is the intent of service request. So document reference seem to be kind of most generic way of capturing that future expectation.
Yep, that's a
Although
good way of looking at
it was never, I don't think it was ever intended that the clinical context would capture intent of what's being asked. It's the context of the intent. So the
Correct.
intent is captured somewhere else. But here it's, you know, and obviously trying to balance existing behaviors with desired behaviors. At the moment, as Angus said, it's basically a bit of a catch-all for anything else you want to say that might influence the delivery of service. And I think we would need to be quite careful about trying to constrain that and shoehorn it into something that was far more constrained in its intent.
Sure. What I meant by intent is really expectation of something, some key information to be captured. Not necessarily intent, but some other information. But it's about future development as opposed to observation and clinical impression, which is about something which is capturing what's happened. So I'm in a line you're saying.
Don't forget that when you're recording that context, the context is not recording a future context, it's recording the current. So for instance, I don't know, patient's a heavy smoker, right? You're not kind of recording the fact that they will be a heavy smoker in future, or at the point of care, they'll be a heavy smoker. But more generally, you know, things like if there is currently, let's say there's no place to put allergies and alerts, then you'd kind of package them in here as part of that context. Current medications, if yes, there are other places we could put that, but if you were having some just handwritten notes on, oh, by the way, the patient's on this, it then becomes the something quite general, and sometimes you might say, things like you could have something that is an impression for the future to say, I know that when the patient rocks up for this service, there will be just this clinical context applying. But you also might equally say 10 years ago, the patient, had cancer. So it runs that whole gamut. And I don't think we, at the moment, are too precious about constraining that.
Sure.
I was going to.
The whole point is that it is capturing things at the point of doing service request, whether information is to do with the future, whether it is to do with the past, or whether it is to do with present. But on the other hand, observation and clinical impression is about capturing something which has happened, which is close to what Dave's talked about, event.
I'd also point out too that we do have, and it's coming in the next couple of slides, we do have other supporting information, right? So we're preparing to have structured information about pregnancy status and adverse reactions and problem diagnosis, right? This is like the fallback. So if you want to tell us their pregnancy status, we're going to have a discrete atomic information where they can tick a box, the patient's pregnant or not, and fills in that. But what we're talking about here is almost that catch-all. There was no way to say what I want to say, so I'm going to write it in this box.
So,
next slide.
I was just going to comment too, Angus. The document reference to me, the description of that sounds like it's more about like attachments. When you're talking about PDFs and things, that's a lot bigger than just that scratch pad that people currently use. Like it sounds like that's more used for like a clinical referral and you want to attach a bunch of other reports that are a lot bigger than just a short sentence. That was, I guess, my reservation about document reference. Observation, I agree with all that. It just, for this, it seems like it's just a simple field to write. I think your description of the scratch pad is, it could be anything. It could be why it's being done, but it could also just be notes that they've got an appointment next week or whatever it might be. I was wondering I think I've talked about this every other meeting about what the overarching resource for this is, because I think you mentioned like the US generally has pathology as like the service requests are one at a time, where in Australia we've got that idea of an episode. And do we, like some of those other resources, whether we have a task or a bundle or a document, they've all got note fields as well, I think, or most of them do, whether that's, because you mentioned it's that overarching thing, and whether it is like the parent task for it all.
Yep. So
their options.
yeah, so a few things there. So I'm with you and have struggled with this and sat a bit on the fence that I feel document reference is like a very large hammer to hit this problem with. As you say, it can point to all sorts of things. We are certainly, if we're going with document reference at this stage, as it said down the bottom, we would profile it down to say this is just going to, the document that we're referencing is just this piece of text. It in the future could be expanded to point to PDFs and spreadsheets and Word document, whatever you like. And that's an advantage that you could do that in the future, but definitely at this stage, we're just saying text. And that's kind of like I pointed out, it has to be base 64, and this is implemented concerns, right? The end user doesn't see any of this, so they don't care. But yeah, observation is kind of like a nice simple thing, but then if you read it, observation's meant to be something quite succinct. This, whereas this isn't.
Yeah, I guess the thing I like about the document reference though is that we're really going to exercise the classification structures here to recognize just what kind of document are we referencing. Oh yeah, that's just, don't forget, tell him to take his meds every other day or something.
Yeah. Well, it's going to be a reference to a document called referral note, and it's going to have a string in it, but on the other hand, you could have an observation. I don't know why you couldn't use the same code, referral note, and it can have a string, which is blah, blah, blah. It's just that then people might look at that observation and go, that's not an observation. That's your Miranda. It's you just writing a whole lot of text, right? But of course, if the observation has a code of referral note, I wonder, are we splitting hairs? But I'm not sure. But back to your other point, I'll just go back a few slides. I think I can. No, must be forward. It's going to be
slide 15 talks about multiple slices versus bundles.
Yeah, this is jumping ahead, but to Matt's sort of question about using note. So we already have made a decision at a few weeks back. Maybe if I jump to the actual. So this is coming from service request, which I had here somewhere, service request. Yeah. So we're going to have a service request per order item, per exam, per test. So, a request might have 3 ordered items on it. There will be our group task, and then it's going to point to 3 of these resources. Each of them potentially can have a note here, but that was the problem and decision we made earlier, that's problematic if you want to write something global for the request, like patients HIV positive. You'd have to say it 3 times, and then the people who consume it might need to dedupe that, and that's difficult, right? But if we use supporting information pointing to one instance of a document reference where it says patient HIV positive, then the deduping problem is really easy for implementers. They just go, well, it's all the same. They all point to the same resource, so it's the same content for the group, right? Does that sort of help the other part of your question you had?
I agree with about not putting it on the service request. Otherwise, if you've got 15 tests and you've got to repeat the same thing 15 times, but just whether when the transactions, so I think that previous slide you had about with the task group, I'm toggling between screens here, so I'm getting lost on what screen I'm on. But whether, I think, does task have a note on it as well? So it's got an annotation. So that task group.
So you're sort of thinking maybe the group task would hold the note. Is that kind of where your mind's going?
That, or even the other side of that diagram look like it's pointing, it's got two outs. It's not really one. I guess in this, do we have the concept of, like for what we think of now as a pathology, that bit of paper, do we have a single resource that like represents that thing, like this whole transaction?
Yeah, that's kind of getting to the problem we have. Like we have a group task resource, but it's kind of about fulfillment. It's not about the delivery of the clinical content, right? It's more about like who's doing this, what stage of the process is it up to. You know, it's not really scoped to hold anything about the actual clinical content, the tests being requested, why they're being requested. That's the job of service request. But then we do not have a group service request, and we kind of have been through that decision as well. Like, so I guess this document reference is what we're describing here, is a document reference that is the global comment for the group, because there is no other resource which is apart from task group, which is positioned as global, right? You know, I don't know if anyone else is, you know, I think we struggle with putting it on group tasks.
Yeah, I think it's just that document reference, like you said, seems like a hammer. Like, and the I think the loin code that mentions, like you said, that could be the observation code as well.
Yeah, I'm kind of with you there as well. Just going back. Yeah, I find this comment a little weird, that inherently supports via document codes binding referral note being a potential candidate for clinical context. But then over here we say no suitable codings, you know, for, I guess, for category, they're saying. So but I don't think this is true, or observation code to distinguish. Well, why don't you just use that code? Like, why can't we use that code here, right? Sorry.
Yeah, I'm sure there's like codes for a lot of.
I guess we should look at this. So observation category, right? So if we go to observation, we have this property called category, and they're putting in here things like, are they putting in here? You know, social history, vital signs, imaging, laboratory procedure, exam, therapy. Does any of them suit what we are calling a referral note?
There's also optional cardinality on that element though too, I think.
Yeah, do we have to have it? Category, it's optional. You just not have a category if you want. I think the most compelling thing against observation is that its description of sort of, it's funny to say I have an observation of referral note. You know, what is that? It's not discrete, is it? It's like I have an observation of a document. I think that's the most compelling reason against observation. But I am, as an implementer, if someone has to bloody do this, I'm with you that it is really nice and simple. It's like a value pair, referral note string. You know, where
I'm far less worried about the coding of it. I don't have any issue to say I'm actually documenting an observation about a clinical history, and this is a broad basis. I'm putting some information in here that I'm observing would be I don't know whether I'm assuming the observation has a focus, which is probably defaulting to the subject.
The actual focus of the observation when it is not the patient of record representing something or someone associated with the patient, such as a spouse or parent or fetus or donor.
You could have the focus as being
The service request.
the set of service requests.
Yeah, the list here.
And
so,
then
so you don't think the focus is about the patient? Like if it's a referral note, I can understand why it could be the service request, but isn't it also the patient? Like it's a referral note about.
Yeah, I hadn't read the thing. I mean, clearly it is about the patient. I guess what I'm saying is that I am far more relaxed that I don't think it's that strange a use of observation. Observation's a pretty broad kind of thing. An observation can be something like a clinical finding, can actually be a measurement. It could be a set of data that you've elicited and observed relative to the patient. So there's a number of, it is a pretty generic hammer to hit things with, but I don't think that's necessarily a bad thing.
If I could just ask again, so on this, like we were saying, on the service request, if there's 10 things I wanted, and so I've got 10 service requests, and you're saying you wanted to include a note to say, oh, this guy is HIV or whatever, rather than repeating it 10 times, isn't that really something on the service request where you've got the subject is the patient and you'd hook something off the patient to be describing that characteristic?
No, because this is in particular the clinical context for the request. It's not for the patient. So you still need to link it to the service request. The benefit of doing this is that it gives you a way of sharing a common clinical context across multiple service requests. And then, because we went through this thing of saying we don't want to artificially create a resource to represent the group unless it was a very concrete reason to do it. And the sharing of content across requests is not necessarily that compelling need. And because we know we already have a de facto group through the group identifier anyway. So the thing that drove the task group was discovery in some ways of the order, but we don't have a pressing need for that discovery for the service request group. So it's a little more difficult to create the full justification. The problem then comes once you have some representation of group, then you've got to get into a whole bunch of things when you've got overlapping content between the group and the children. And you have to make rules up around what is or isn't appropriate override semantics.
Yeah, you're going hard there, Andy. Beatty.
So I'll go to the next slide, which is about what there is this proposal here. So someone's pushing us hard for document reference. So adopt document reference as the preferred FHIR resource for representing clinical context in AU requesting. It will be constrained as AU requesting R1 as follows. The document reference type shall be this low encode referral note. Document reference subject is mandatory and must reference an AU call patient. Document reference content dot attachment shall be mandatory. The document reference content dot attachment content type shall be mandatory and constrained to plain text for clinical narratives. I don't really know if you need the last sentence there. It just will be constrained to plain text. Document reference content attachment data shall be mandatory to ensure data is provided in line and it's base 64 coded. Must support and default obligations on status type, subject, content attachment, and content type and data. So
given this discussion, I'd be curious. I don't know how we could do this. It'd be interesting to see a vote on where people are leaning. Like,
yeah, I agree.
I don't know. I don't think there is necessarily a compelling argument either way, to be honest. And I hear what Angus is saying. As soon as I see the words, I see base 64 encoded text, I'm just going, gee, that's, we're creating a lot of work for something that's most cases going to be pretty simple. And so that leans me back towards the observation and just doing it in a structured way, knowing the fact that we are going to look to lean towards more structured supporting information over time. There is the other issue I think Angus and I have talked about in the past, which is, we want to be backward compatible with systems that can't necessarily deal with the structured content. And you don't really want to be in the situation of artificially replicating narrative versions of structured content into clinical context. It all gets really messy if you start doing that. So I do think that if we have rules around ensuring there's a narrative form of structured content, and as we push more and more then into that structured content and allow for the narrative associated with it, there's going to be less and less need, I think, for potentially this unstructured collection of context. I would hope eventually.
Yeah, I think that's a big hope, Andy, but I get your point. But, yeah, like I said, they often use this field for weird and wonderful things that you would not even call clinical notes.
Yeah. So I don't know. It's I don't know if we can.
I
maybe
agree.
just raise hands or something, just to say, if I said, who thinks we should go observation, and just put up your
yeah. So let's go
maybe
back to this. Let's do maybe a vote on all three. I think it's really going to be the first two. Okay, so let's do a show of hands for who's leaning towards document references.
I could do a custom.
Yeah, do a poll. Yeah. Just choose between those three, I suppose, if you can. Yeah.
Not wanting to put you on the spot or anything.
I also think there's an agenda. There's a lot of going on in Spark about the patient summary, and I feel people are leaning us into document reference because they think it's going to link into the referral note being the patient summary, or at least they've got blinkers on going down that pathway, right? So it's kind of like, oh, use document reference because then you could point it to a patient summary. And I'm just like, yeah, but
it's a lot of
information
information in a patient summary.
Yeah, a patient summary is not a referral note. I just think, they're all playing heavily with patient summary, which is a document, and then they're applying that hammer to everything else they can see. That's why they're pointing us to document reference.
Nice.
So here's the vote.
Made it multiple choice, so you can.
Yikes! I can sit on the fence here, can I?
No, you're not allowed to pick.
Them
Can't
all.
pick something else. Yeah, can you click them all? You can. Don't do that.
You don't have abstain in there.
Oh, let's not get picky.
Don't vote.
Just cancel the vote.
Just don't vote.
Yeah. Not a formal vote. We're just trying to work out which direction, I think.
And if you do say something else, we are going to ask.
8 votes. Does anybody else want to vote? I'll leave it open for another couple of seconds.
We actually scared a couple people out of the meeting.
multiple choice questions are hard. All right, I'll wrap that one up. Everyone done?
Yep.
Cool.
Dun, dun.
Yeah, it's not the election.
Ooh.
We won 60-70. Yeah.
It is very much like the election.
There's quite a few something else's there. Did someone want to maybe voice what they thought something else would be? Or is that just 20% because there's like 8 votes and is that like one person?
It's 2.
That might be abstain.
I did a split vote. I did observation, but also there's something else because
You feel
yeah,
like it's not
just-
perfect. Something else
Yeah,
without
like-
actually knowing what the something else is? Is that where you went?
Yeah.
Yep.
That's what it was.
Well, I think that's interesting, and I think that makes makes it difficult to have this motion.
One other question I got is, if we talk about it as a document as opposed to an observation, are we saying that these notes that we're capturing here, they're never going to be like, subpoenaed or anything like that? So that we have to do sort of document management around them. As long as we're saying that that's not the case, and I guess I'm less tied to document reference.
Well, they still will be part of the clinical record for the request. So I don't know if there's the only really thing that document manifests gives you is kind of it takes a set of things and has you manage them as a whole, whereas both of our options are pretty much going to do that anyway, because I think we would not, I don't think we would want to allow replicated observations of that type. We would
But
want
you can't replicate an observation because every observation is a new one.
True.
Okay.
But I think you're making a fairly good point that the observation or the referral note, whatever it lives in, has no life outside of the group of requests, right? Like they're saying this in regard to this request they're making to a lab, right? They're not saying it as a global statement about the patient's record, forever. They're just saying, this request I'm sending to the lab, I want to tell you this, They might say patient has a fear of needles, right? Now, I guess you could put that, like it might be a young patient. They say patient fear of needles, should that live in the EMR? I mean, that's directly saying, hey, you're going to get a pathology test. They're going to stick a needle in your arm. I'm trying to tell them that, you've got a fear of needles. Yeah. But they're not then also saying, and that should be stored in the global health record for this patient forever.
No,
and I think that's...
And this is where I guess we keep circling back down to the group of requests. Here's a request, and by the way, they're scared of needles, so when you give them those 6 needles, be really careful.
I guess by going by document reference, though, as opposed to observations, other things which are inherently going to be text or coded text of some description, as a document reference, you can include anything. Could be a photo, could be a drawing, could be anything that assists in what's going on. Doesn't have to be text.
True, in the future, it doesn't have to be text. Can it be many? Sorry, I'm just...
In fact, in the case of something like vascular, it could well be a drawing, for example.
Yeah, I think I almost got sold on that example of a drawing.
Vascular surgeon is referring for an ultrasound. Sometimes they'll provide a diagram.
The document reference. Attachment, can be many. Yeah, so it could, you are right. Like in future, it could be blah, blah, blah. Here's a picture. It's certainly not what the proposal is initially. Like here, we're saying content type. Keep clicking. Content type attachment shall be text, plain text, but it could expand in the way you're saying, Craig.
That's to be honest, that would be a compelling argument, because there is nothing in observation that I can see that would let you.
There's attachment, isn't it? As we were just told in this comparison here, support for attachment using a value attachment, but this may be considered semantically inappropriate.
Value attachment. I think there might be in R5. Hang on, let me look at R5.
Should stop going back and forth between these two.
Yeah, it's only in R5. It's not in R4.
Right. Yeah.
So yes, you could kind of use an extension to add that.
Mm. It's funny, you can have a note on your observation. You can have a referral note and then have a note about the referral note. Yeah, there's no attachment here, but as you say, it's in R5. Status would be final, I suppose. Yeah, everything else is optional. So look, we probably need to move on to the next topic, but shall we try and have an actual, like the poll we just did, do a rather than having this formal vote on this, have the formal vote about observation, or I suppose we just did it, didn't we?
Well,
I don't want to go to this vote, because this vote assumes you've made the greater decision, you know, which I don't think we have. Or we could just vote this down.
Well, I think we have to vote in the positive if we, you know, and by the poll, like we had more for observation. I think we do need to make a way forward, because otherwise I think we're just going to kick this can down the road and go back and forth between them.
Well, I'll move a motion. Like I'll move a motion that we use the resource observation for clinical context, clinical note. It's simply that, like the detail about what would be, how, you know, the properties in it. I'm thinking we're just going to use the referral note code as the code, and it will be a value string as the data type, and pretty much everything else would just be not required. But I think the motion I want to move is that of the choice of three, I motion that we use observation for referral note.
I'm happy to second that.
Okay. So we shall go to a vote. If I can get it to run. There we go. Okay, so the current motion is that we use observation for clinical context. There is a poll appearing on your screen. You may vote affirmative, negative, or abstain. I will keep it open for 30 seconds.
I wonder if the pre-polling was correct. You never know.
All right, and closing that one in 3, 2, 1. And there are the results. It is 7 affirmative, 5 abstained, and 3 negative.
3, yeah.
So that has passed. We shall use observation. I don't think, though, that constrains us from introducing a document reference in the future, though, if we need documents.
No.
So just so that I'm just sinks in my head there. Sorry, Andy. So the good thing about observation, using observation, is that it's easy to implement right now. Is that right?
Easier, yep.
Easier. Is that the primary reason why we're going that direction?
Primary reason? It's probably a compelling reason, given the two kind of strong candidates, that we don't see a significant difference in how they're constraining us going forward. That probably is the tipping the balance.
Right. And so I'm in there, the GP's they're making an observation. Oh, that's your heart rate. Oh, geez, here's another observation. He's looking really bad. As a note observation. Is that what we're, so the
No,
observation is yet collecting another type of measurement or
It's an observation of type referral note.
referral note.
So I've written here under the context of referral note. It's not stopping us having another observation for pregnancy status. You know, we have sort of semantic rules that we please don't in referral note say patient is pregnant and then not click the pregnancy status is false. You know, like don't contradict yourself, but we can't control that, right?
Yeah.
So we certainly will, and over time grow the array of other supporting information. So, you know, allergies and alerts, problems, implanted device, pregnancy status, all structured atomically. But this is your fallback catch-all with the heading referral note.
Yeah. Yeah. No, don't get me wrong. I'm making sure I'm on the same page as you guys. That's good. Thanks.
I'm just wondering though, given that we are a small group today, and this is so close, and we have here at least on what screen now some attempt to previously do pros and cons and do some level of comparison, and yet we've somewhat, if you look at that particularly that diagram there, we've basically said, look, we've ignored all the green ticks and we've gone with all the warnings, and said that seems to be the better view simply because we think it might be easier. Might not be the best explanation when people look at this later on going, why did they choose that?
Yeah, I'm happy to take it to a wider group.
It's an interim decision, perhaps.
This slide wasn't created by a quorum. This slide was created by an individual.
Yeah, so I'm wondering whether the step to getting the right decision is actually whether you want to debunk what the ticks are and the warning signs are, and whether they actually this graphic itself has a bias that needs to be thought through, because many things that are in programs I see lots of things where people do all these sort of analysis and they present some sort of graphic and then completely give a completely different recommendation about what they should do, right? So in terms of having an argument that says we made this decision based on all the knowledge that this points in the right direction. Yes, it's not perfect, but it's the right direction. Whereas, here we're just going to go, okay, a small group of us have said, maybe this one will work, maybe we could do it this way, maybe we do it that way. And I think this one is potentially one of those ones where we already know it's been in a couple of meetings before to get discussed. So there's a lot of contention around it. So is it not just the best decision to try and make a vote today and
well, how about we record
present our results and saying, look, we sort of came to this with a smaller group, but we felt maybe it needs to be a bit broader.
I do agree with you, given we have a smaller group here between Easter. I think maybe we don't record that as we record that we had a vote and we went this way. Like I agree. I don't think we should take this smaller group here and override, evidence is sort of pointing another way as the Bible. We probably need to re-vote with the greater group. But I think what we've done here is shown that there is people objecting to the way we're being pushed, right? And therefore we're not going to have this next vote, which is just jamming down our throat that you're going to do this and you're going to do it this way. There's dissent against that. So I agree. There's more. It's still close. This is a small group, so I'd like to treat this as there's more to be had here than I agree. We don't lock it in today, but we don't I struggle to vote on this slide.
Yeah. In the comments, Janie, we do not want to tie the clinical context in formality. Do you know what that means?
Here, Jane, in clinical context and formality.
Yeah, I think if you're completing this with a whole lot of documents, as well as being repetitive, it's really tight. This is what I'm calling the formality, having, if you like, legally accepted documents. This is something that needs to be written specifically for the request.
Look, either way, at this point in time, people are only scoping it's a string, right? Whether it's a string in an observation or a string in a document reference, at the end of the day, for the user, it's a string, right? It's just, I think the argument is about simplicity today and extensibility tomorrow. Like, I think there's people here, which I'm probably in the camp of, like, keep it simple, stupid. Like, it's the simplicity of one, but the counter is the more complex but more extensible in the future other way. And I think we're caught between the two.
Given the time, would it be worth having a look at the different approaches of how to do supporting info? Because I think that slide 16, that clinical context bucket could easily be an observation.
Yeah, so let's maybe record the vote we've had, but it's not, you know, there's more to be had here. But let's move on to the next slides because they're still in this space, and I think they add to the conversation. So, and we're running out of time.
Yeah, sorry. Before you do that, Angus, I just wanted to note that since we have voted on it, it is a binding vote, but we can come back to it and review it again. So, in the absence of a second vote, that observation decision would stand. But I think we agree that we need to come back to it and do it again.
I think there's an 80% on that as well. If we actually want to reverse that original decision, we have to get 80% of people agreeing.
Yep.
But that's fine. We can do that now and get the 80% if that is what we all agree that we want to retrofit a new interpretation of the vote. As long as 80% of the people on this call go, yep, we're happy to do that, then we kind of can cover that off.
Do you mean vote now?
Yeah.
To unvote the one we just had.
Yeah.
Now I'm happy to do that.
Is that a motion, Andy?
Yeah,
as opposed to waiting for a larger audience.
Well, when we wait for the larger audience, we still then have to get the larger audience to agree that the vote that was previously agreed to should be changed, and that would also need the 80%. So it'd be easier if we truly do think this now, and we're not undermining a majority of opinion on this. It'd be easier to do it now than it would be to wait.
I hear you.
Do it in the heat of the moment.
Okay, Andy, so you are motioning to unwind the vote.
I'll support.
Yes.
It'll all be recorded for the greater vote.
That?
Yeah.
I'm supporting the Zoran.
Thank you. Okay, we shall relaunch. You are now voting for the current motion. The current motion is to reverse the previous motion. I'll leave that open for another 5, 4, 3, 2, 1. That is affirmative at 64, but it is not the 80% needed to unwind the previous motion. We will have to come back to that in the future.
Yeah. Well, the larger group can vote. We can have this vote again. This vote again with the large group.
We can. Yep. That's
which
fine.
I think is reasonable.
We'll sort it out.
All right. I think it's timely to move on because I think it even adds more color if we move on to. So the next one is Diagnostic Request supporting information, which is a greater wrapper around the conversation we just had. So we had a vote on the 27th of March, motion that there is not to be overlapping information held in service request.note and service request.supportingInfo if there is the intent to specify common administrative or clinical information across the group of service requests in order to that should be represented within the supporting information attribute as a commonly referenced resource. So that was really just this. We voted that if you've got something global to the whole request, it should be in its own resource and all the resources point to it, not repeated over and over in every note field, was the decision we made. And therefore you get this diagram that many diagnostic requests, which are service requests, point to a common resource. So that's just some context. So eRequesting data requirement, the requirements that may be suitable for representing in diagnostic request supporting information. So clinical context is that thing we just all talked about, clinical notes, narrative information provided an overview of the individual's current clinical situation. But there are these other things. So problem and diagnosis summary, a summary or overview of the single health condition, injury, disability, or any other issue that impacts the physical, mental, or social well-being of the individual, and adverse reactions in a summary and overview of clinical assessments that identify the potential harm or undesirable physiological reaction unique to an individual and associated with the exposure to a specific substance, and then supporting information to be defined in the future, so other things in the future. So you can see that our clinical context, our clinical note, just sits within an array of other stuff as the sort of catch-all. Like if you've got a problem diagnosis, then please provide it as a problem diagnosis or an allergy. But if you just want to say something off the cuff, there's nowhere else to say it, clinical context. So options for implementing supporting information. So multiple slices, the next slide is a diagram that will explain this better. So multiple slices, a discrete supporting information slice for each supporting information resource. Document bundle, one supporting information slice for all supporting information contained within the document bundle. There's the discussion page. We'll look at that in a sec. But I'll go to this diagram. So really we're trying to make a decision between, do we, within supporting information, have a list of links pointing to each of these things, the clinical contents or clinical notes, pregnancy status, allergy intolerance, implanted devices, on and on. Or this approach, which is the supporting information points to a document bundle, and within that document bundle, you have all those things. These was the pros and cons. So multiple slices. So data structure, simpler data structure. That is, you don't have the document infrastructure, right? It's just a list of information not contained in a document. They're more complex for a document bundle. Extensibility, extensible pattern to support additional supporting information for eRequesting, so you can add more slices over time. The other one's inherently extensible to support additional supporting information for eRequesting. You can add more to the document over time. So really, they almost null each other out. Query efficiency. So to retrieve all that supporting information, you'd potentially have to make multiple queries or includes are required to retrieve all the supporting information. Whereas on the right, you just have to retrieve the one document bundle and you've got it all. So possibly many queries on the left as opposed to one on the right. Profile maintenance overhead. So it requires diagnostic request profile updates for every new supporting information resource that is added over time. So today we might have 5, but tomorrow we have to add a 5th one. We have to update the profile to say there's now this 5th one. As opposed to the right, diagnostic request profile doesn't change when new supporting information resources are added to the document bundle profile, i.e. profile changes are isolated to the bundle. Really, you're just moving it around, right? You don't have to change the service request profile. You've got to change this bundle document profile. Supporting info structure orchestration. So on the left, it's a flat list of supporting info references. On the right, the the use of a composition resource to provide structure and organized representation of supporting information. I think what they're getting at there is the left-hand side is like a non-ordered list, like pregnancy status, implanted device, allergies and alerts are just their own little island of information. Whereas if you put in a document, if need be, you can arrange it in a set way. You know, you could say, oh, we want the referral note to be first, and then, you know, you can order the order that these things are in. Alignment with existing fire patterns. So fire slicing used to support eRequesting. An eRequesting document bundle would be a similar approach to how IPS models a document. Granular flexibility. So on the left, allows for fine-grained control by labeling different pieces of supporting information to be applied selectively to individual diagnostic requests within the group. Each request can reference its own relevant supporting information. So that being, if you've got a piece of supporting information which is only relevant to one particular test, say hepatitis, then you can just have it on the hepatitis request. But if that piece of information is only relevant to one of the tests, and we go with the right-hand approach, then somehow it's now relative to all of them, even though it might say this is only relevant to that one test. So on the right, all or nothing limitation. If the supporting information document bundle is referenced, it cannot apply variability to different diagnostic requests in the group. So I guess they're saying the one on the right is global to the group. The one on the left could be, you know, different requests have different supporting information. So this is the motion being put forward. Motion, a supporting info approach. So we're trying to make a decision. The preferred supporting information approach for eRequesting diagnostic request is multiple slices, a discrete supporting information slice for each supporting information resource, or a document bundle, one supporting information slice for all supporting information contained within the eRequesting support info document bundle. Support info slices on eRequesting diagnostic requests are must support cardinality 0-1s. They're optional with default obligations. Add clinical context as supporting info on eRequesting diagnostic requests using the preferred supporting info approach. So the thing we talked about earlier would have to align with this. I think, yeah, we'll go back. So I guess open up for any questions on this, and we are running out of time.
So supporting info is there at the request level. Are they saying on the bundle, the supporting info goes away so that I'm not going to have my opportunity to put supporting info on each instance?
Yeah, if you go back, so this is
that's why I was trying to remember this.
Yeah, this is the bundle way, right?
Yeah.
Like each diagnostic request, service request is going to point to a reference to a document.
Yeah.
And then that document has all the granular information within it. Whereas if you do this way, it's say one of the requests has, I don't know, allergy intolerance on it, but the other one doesn't. I don't know, you know, whether it might not make sense in the context of allergy, but in the future, you might have something that's specific to a test type. And it's, you know, now if it's in a bundle, in a document, it's kind of linked to all requests, even though it's
I guess I didn't understand why bundling it would drive the need to pull supporting info out to the group level. Like you've got it here at the lowest level, don't you? At the clinical context, what's the supporting info for that? Or actually I got it the other way around. On the diagnostic request, the supporting info is this clinical context, right? Yes.
I think maybe it's not clearly saying that surely this for this approach, the next approach, for this approach to be feasible, surely that document bundle has to have the context of global. Like, let's say you're ordering hepatitis and you want to provide clinical information about the immunization. And I guess you can put that in the global, but it's really about one of the tests, right? This kind of rules out or makes it unclear how you provide a piece of clinical information about one test and not the whole test.
Yeah, because I wouldn't have taken, I would have left supporting info into each one of them anyway. Anyways, that's
I think there's a third option here, which is the hybrid of the two, right? Like, yes, you can do that, but you can also, in some cases, do this, right? It's not, to me, it's not all one or the other. It's, I think maybe it's almost missing the context to say, are we just talking about global information like allergies and core conditions and pregnancy status? They're all global things, right? But in the future, there might be a piece of supporting information that's not global, and therefore it makes little sense to be in a global document. Therefore, the hybrid approach is kind of. I'll jump to the page because there were some comments someone made at the bottom of the page about this. So this is the discussion page we had. So right down the bottom, some comments were made. So Heath said, for patient summary, why not just reference the bundle directly? See, this is this influence of patient summary coming in, sort of like, is this supporting information patient summary? Referencing a document reference means you have to reference you have two references to resolve before retrieving the item of interest. So you got to go through the document reference and then follow its reference to some bundle. Perhaps it's too early to suggest one approach over the other until the patient summary approach for exchange is decided by the patient summary project. Aside, there is definitely a requirement for document reference for PDF, Word documents, etc. So it is safe to include a slice for this, and a further slice could be added for bundle if deemed appropriate in the future. And Steph replied, hi Keith, thanks for your feedback. Good point about document reference wrapper for a bundle possibly being redundant for AU eRec. The discussion page has been updated for further review. The second approach now proposes a slice for the bundle.
Sorry, we might have to wrap it up there. We're right at the end of time. Could you quickly show up on your screen the next session slide, the very end? We're obviously going to have to come back and revisit some of this stuff again.
This, you mean?
No, keep going past that. We'll have to come back to that later. This one at the end here, yes. So thank you everyone for today. It was a good discussion. The next meeting is on the 8th of May, and we have 4 more meetings before the testing event in Brisbane. So we're going to wrap it up there for today. Thank you everyone for your time, and we look forward to seeing you on the 8th. Cheers.
Thanks, guys. Good work.
Thanks,
Thank you.
Cheers, bye.